Okay, sorry about that, everybody. Sorry, I have to start over again with roll call. My apologies. Angela is here. Carla B is not here. Elizabeth Bullhouse is not here. Chris Bossy is here. Phil Burrell did not sign on yet. He is not here. Tom Clark is here. Jody Dominic. Jody Dominic is not here. Vance Farrow is here. Joseph Greenway is here. Joan Hall. Joan Hall is here. Maya Holmes. Maya Holmes is here. Shayla Holmes. I do not see Shayla. Lawrence Lerner is here. Ashore Lissac. She's here.
I'm here.
Karen Massey. She said she'll try to join us when she can. Tom McCoy. He's here. Thank you. KYRA Morgan. KYRA's here. I saw her earlier. Stacy Sasso. I don't see Stacy. Todd Sklamberg, he was only going to be able to be here at 1 o'clock. Jennifer Wakeham, I see her here. And I see Bill Welch. All right. In light of the fact that I can't hear anybody and I can only see you. Oh, Stacy Sasso is here. Thank you. I'm going to go ahead and get the meeting started. We can start with Michael's presentation. And everybody here, Michael, when he starts? If so, then we're going to go ahead and we'll do the introduction to our PPC Executive Director when she can get back online. And we will skip over public comment and come back to that at the end. But let's get Michael started on his presentation. So, oh, sorry. Melinda is on as a panelist. Okay. Do the same with Phil Burrell, who just came in. Bear with me. Thank you so much for your patience. Okay. So, I think we'll go ahead and get started again. Apologies again. I'm going to try to also make Melinda a co-host, and at least maybe you can hear her.
Hi, everyone.
Okay. All right. Sorry about that, everybody. This isn't my first rodeo. Don't know what's going on today, but Melinda, you're going to have to take over the meeting. I'm going to be here, and but I can't hear anything, so not sure what's going on with my equipment. But you might as well introduce yourself and see if everyone can hear you.
All right, sounds good. So hi, everyone. My name is Melinda Southard, and I'm the new Executive Director for the Patient Protection Commission. I'm super excited to be here with you all. Some of you are familiar names, and others I have not yet had the opportunity to meet yet. So I just wanted to give a quick introduction of who I am. So I was born and raised in Amador County, California, in the middle of a forest, and I went to chiropractic college in Portland, Oregon. And after graduating chiropractic college, I had some friends who lived in Gardnerville, Nevada, and decided, hey, that sounds like a nice place to live. So I moved here in, what was that, like 2009, and started my own practice in concert with another established practice here in Carson City. So I had my own chiropractic practice for almost 5 years and really enjoyed every minute of it, and, you know, seeing patients and helping them to live more healthier, active lives, and just enjoying that that light that you see when somebody understands what's going on with their body, why they hurt, and how they can avoid that injury in the future. So just really exciting stuff. And let's see, then as I was nearing that 5-year mark, I had gotten married and started a family. And, being self-employed doesn't come with those lovely health insurance benefits that y'all look for. So I decided to retire as a chiropractor and start my work with serving the state of Nevada. So started briefly with Nevada Medicaid and then moved over to the Division of Public and Behavioral Health, where I've been in the public health preparedness program for the past 7 years. So that program is all about public health and healthcare emergency preparedness, for those of you who don't know, and just had a lot of different collaborations across, emergency management and public health and hospitals and healthcare and EMS and just all kinds of partners and collaborations together. It's a really exciting time. And now I am with the Patient Protection Commission. So really excited to be here with you all. And I want to thank you for your service to this subcommittee and helping to put forward some really great recommendations to the PPC, especially about the cost growth benchmark. So with that, I will, we will go to, okay, so we'll go to, have we done the minutes yet? We've not done the minutes yet, correct? Okay, perfect. So I will, everybody has been given a copy of the minutes. Can I please ask for a motion to approve the minutes? Don't all jump in at once.
So moved.
Yes, second.
Excellent, thank you. The minutes are approved. With that, we'll move on to agenda item number 4 is public comment. So public comment is limited to comments on items on the agenda. No action may be taken upon a matter raised under public comment period unless the matter itself has been specifically included on an agenda as an action item. A time limit of 3 minutes may be imposed. A person may also have comments added to the minutes of the meeting by submitting them either in writing or testifying in addition, or in lieu of testifying. Written comments may be submitted by email to the PPC info@dhhs.nv.gov email before, during, or after the meeting. Just want to pause and see if there are any public comments. And please raise your hand if you have a public comment. All right, seeing none. We will move on to item number 5. And with that, I'm going to turn it over to Michael Baylett to give us a analysis of the key findings from Medicaid's and PEB's phase 1 cost driver analysis. Thank you.
Thank you, Melinda. And hi, everybody. Nice to be with you again. So there are a few topics I'm going to cover. The first one Melinda just indicated, but before I jump into it, I want to give you a sense of where we are in the flow of meetings of the Patient Protection Commission and your meetings. So we had a meeting that was scheduled for April 14th. That was going to be a presentation, a fuller presentation than you'll have today of the Medicaid and PEB phase 1 cost driver analyses. I'm going to give you a condensed presentation today. Since we were not able to meet then. So on April 20th, the PPC received the full presentation. They also received an introduction to the broader strategic plan for conducting analysis, which we refer to as the data use strategy, which is mining claim data to get insight into what's happening underneath the benchmark and what's driving healthcare spending growth. They also had a discussion about population thresholds for public reporting of provider entity performance based on some statistical analysis done in 2 other states. So today, we're going to do 3 things. First, as Melinda indicated, I'm going to give you key findings from the Medicaid and PEB phase 1 cost driver analyses. 2, I want to share with you what the PPC discussed for criteria for prioritizing cost growth mitigation strategies. And 3, I want to invite you to reflect on what some strategies might be. So I want to pull back and just remind you of the context here. The governor established a cost growth benchmark in an executive order in December. We now are going to see today some analyses to give us some insight into what's been driving healthcare spending growth in Medicaid and in the public employee benefits program. We're using that as a proxy for the commercial market until the state's all-payer claims database is built. And the reason that we're looking at those data is we want to understand what's driving cost growth, because we want to then have the PPC recommend strategies that will help ensure that the benchmark is met and more fundamentally, that healthcare spending grows at a more affordable rate. So that's why we're looking at everything today. In terms of what's on the docket for the PPC, their next meeting is May 18th. They too are going to talk about cost growth mitigation strategies for the first time. They're also going to discuss narrowing down a set of, I think, 16 ideas that they've generated for bill draft requests for the 2023 legislative session. And so that's what's immediately next on the docket. We do not yet have an additional meeting scheduled for the advisory subcommittee. So the other dates that you see here coming up are all for the PPC. Any questions about any of that before I go on? Okay. So I'm going to start with this cost driver analysis, and it's referred to as phase one because there are a second set of analyses to be conducted that will dig more deeply into some of these topics, but this was the first cut, and it was generally performed in parallel fashion by Medicaid and by PEB's contractor, Aon. Not exactly the same, but pretty close. So I'm going to walk through these. This is a somewhat condensed version of what you received via email prior to what was to be our last meeting. Noting that KYRA is here and that she developed the Medicaid slides, I'm going to invite her to jump in at any point in time. But I'm going to try to pull out what I think are the key findings that warrant your attention. And when you look at this, think about it in terms of what does it say about what's driving healthcare spending, and what does that mean for potential cost growth mitigation strategies that would target these cost drivers. So I'm going to flick back and forth between Aon's analysis for PEB and Medicaid. So you're going to see a change in slide format because their looks quite different, but I'm going to go back and forth and hopefully you don't get too rattled by these changes. So first, PEB looked at claim data from March 2017 through December 2020. And so we have multiple years of data, and we know in 2020 that we had aberrant utilization patterns. And so when we're looking at trends, generally I'm going to summarize what we saw between 2017 and 2019 because people almost completely didn't seek healthcare services for 2 months in 2020 and then had depressed levels of utilization afterwards. The Medicaid analysis, which KYRA led as part of the Office of Analytics, was looking just at Medicaid data. And Medicaid, for those of you not aware, covers about 1 of 4 Nevadans. And had phenomenal caseload growth. You can see that 34% in 2021, which is just astonishing. So the data that Medicaid used, also multiple years, so calendar year 2016 through 2020, so a little bit more data than what PEB had, but it gives us multiple years, and that's a good thing. So I'm going to start first with the trends that were identified using the PEB data. And again, we're using this as a proxy for the commercial market. I think it's fair to say that the patterns for PEB are probably indicative of the patterns in the commercial market. Generally, public employee health plans have healthcare spending that's higher than the commercial market because the public employee population tends to be older. But the patterns that drive spending growth should be consistent. At least that's what we've seen in other states. So here's per member per month spending for medical coverage and pharmacy. So this is a crude cut. And what you can see here is that spending in 2020 was down 2%. That's about what I'm seeing in other states for statewide spending, that it was down 2 to 3% in 2020. But what we see in the years prior to 2020 is a pretty high level of growth in the PEB program. The medical trend here is averaging 12% for over 2 years, 2017 to 2019. It's 18% for pharmacy and a total of 13.5% a year. Now, that's only for 2 years. And I want to emphasize it's just 2 years. But that's extraordinarily high growth. Okay, and the fact that pharmacy was growing faster than medical is consistent with what we see in every state. Here's trend data from Medicaid. Trend was much lower, 5.5% between 2016 and 2019. You can see here, but 5.5% is still way above the inflation rate during this time period, obviously not right now, and above wage growth and economic growth. So yes, this is half what PEB was, but it is still higher than all other economic indicators in the state, or at least the leading economic indicators in the state. All right. And by the way, if you've got questions or a comment to share as we go through these slides, please feel free to raise your hand and we can have a conversation about it. All right. So now a little breakdown. PEB offers 2 plans: a high deductible health plan and an exclusive provider organization. The EPO was introduced only recently in 2018. It is a much higher population risk level. So clearly, people who are who've got medical conditions that warrant service use are opting for the EPO plan because it's got twice the per member per month spending. Now in Medicaid, to some degree has 2 different plans. There are Medicaid members enrolled in managed care organizations or MCOs, and there are those enrolled in fee-for-service. The fee-for-service population includes those who are eligible because of a disabling condition. It's referred to as the aged, blind, and disabled, or ABD population. It also includes Nevadans covered by Medicaid who live in rural parts of the state. So know that 2 populations are combined here. The fact that the fee-for-service population has got a much higher spending level is reflective of the fact that persons eligible because of a disability are here, and they have much higher spend because of that disability. Okay, what you'll note here is the trend for fee-for-service was 6%, and for managed care was 9% during this time period. Okay, so this trend looks at what's driving the change in per member per month utilization. And in fee-for-service, it's increases in spend per utilizer. And for the MCO program, it was the same, but also some growth in absolute utilization because the population grew for the MCO program. So increases in spend per utilizer could mean one of 2 things. It could be that people are receiving more intensive services, or that the prices of the services are higher. And we don't know that from here. Okay, but it can be one of the 2. But you can see here that the trend rates for spend per utilizer are higher than they are for utilization. I will share with you that, having looked at data for other states, this is also common that we see low rates of growth in utilization, and we can't call this price because it's not, but generally price tends to be driving spending in both Medicaid and in the commercial market more than utilization, and that seems to be the case here. Right, so here we've got the fee-for-service population, but we've excluded, Chris, I'll go to you as soon as I describe the slide. So here, the population of persons eligible because of disability are removed. So now we're looking at, in fee-for-service, we're looking at Nevadans covered by Medicaid living in rural areas compared to those in MCOs, in non-rural areas. And big difference here. So fee-for-service spend was essentially flat during this time period, and the MCO spend grew 9%. Even though the fee-for-service spend is higher. So this would suggest that either those living in fee-for-service areas are sicker and using more services, or the services have higher prices in rural areas. Chris?
My question related to the slide before.
Okay.
And I just was curious. I was confused by how you described the difference between utilization and the spend per utilizer, because those both seem like utilization to me. And my knowledge, my limited knowledge of the Medicaid fee schedule is there were no increases probably during this time. Maybe one of these years there was an actual increase. So that might be part of this in one of the years that we could go back and tag that to, but I just wasn't clear the difference in how you're attributing the year over year in the utilization piece versus the spend per utilizer.
Okay, let me try again. So spend per utilizer, if it's rising, then it either means that the people who are utilizing services are receiving different and more expensive services. Okay, so imagine that people
and that's
who are
not utilization.
no, because it's the same number of units. It's just that the services they're receiving. So the simple example I like to give is instead of an X-ray, you got a CAT scan.
I got you.
Okay, they both count as one service, but one service is much more expensive than the other. Okay, so it's either that or it's the prices went up. Okay, when we're looking at spend per utilizer.
Okay, thank you for that clarification. And I have one additional follow-up,
Sure.
and that is when we're looking at this data that's aggregated either for Medicaid or for PEB, I'm also curious about when we measure a year, is it based on date of service or is it based on claims paid?
Yeah, it's date of service.
Okay, that makes me feel better because we see lots of volatility, especially in the MCO side with, they change payment rules. And so things slow down at certain times, et cetera. So date of service is great. Thank you.
Yeah, and KYRA raised her hand, and this is her analysis. So, Joan, I'm going to skip over you for a second and go to KYRA and then go back to you.
I just wanted to chime in to the question about the fee schedule, and just I realized that we didn't clarify the MCO dollars here are not the capitation payments that we experience at the state. These are the claims. These are based on claims and encounters submitted by the MCOs, and so this is their cost growth that they've experienced. It is not the direct cost that is observed by the state through the capitation, if that makes sense.
Yeah, these are MCO claims.
Will the total spend be accumulated somewhere? So in other words, the admin piece, the additional spend for the state.
Not here, Chris. When we do the benchmark measurement, we will include the admin piece, but this is just an analysis of a claims database. Okay. Joan.
Hi, thanks. So I have some questions on the Medicaid cost driver analysis on page 19.
Okay, I'm not quite there yet.
Okay.
I don't think.
Well, I guess we could go back to the plan one on 18 then. For rural regions, KYRA, does that include supplemental payments or is that simply Medicaid reimbursement?
So this particular analysis is just claims and encounter data. The only place where we take anything else into account is in the pharmacy section for Medicaid. We did take out estimated rebates.
Okay, and then just a comment, in the rural region, that would include 10 critical access hospitals and one ELCO, which is a for-profit, paid differently than the 10 critical access hospitals, and they're cost-based reimbursed. So just wanted, that's one of the reasons I think that the spend is more.
Yep, I suspect you're right. Okay, Ashore, do you have your hand up?
KYRA, can you explain your methodology for estimating rebates in the Medicaid analysis?
Yes, we actually have a drafted response to that question that we can send out just to stay on topic, or did you want me to pull that up for the group now?
I would love to hear it now.
Okay. So we have annual rebates that are stored in a different financial system than directly with our claims information. And I think there is difficulty in allocating those sometimes to a specific year. And so what we did is we pulled all of the rebates that hit that system annually out of that and compared it to our total pharmacy spend for 2016 to 2020, which is a 5-year period. We found that we get rebates approximately in the amount of 51% of our pharmaceutical costs. And then we essentially did the opposite of annualizing. So we distributed that rebate percentage over to hit each month equally, because we're not sure exactly where those hit. And so that was our best estimate. And then we took that right off the top of the monthly pharmaceutical costs.
So are you estimating supplemental rebates received by MCOs as part of your estimates?
These are rebates. Sorry, I think this question's a little bit over my head. I might have to ask policy. These are only rebates that are accounted for within our budgeting system. So I don't know if that helps answer, or if I should phone a friend after and follow up with more information.
You might phone a friend afterwards, because I think the state, since you contract with managed care, is only realizing the statutory rebates in their system. They're not going to realize the supplemental rebates that would be received by managed care organizations for, like preferred formulary placement and things like that.
Correct. Sorry, I didn't understand your question. Correct. Any rebate that an MCO is receiving is not accounted for. This is only, I believe, rebates that the state is actualizing.
Okay. And then just a follow-up question, why didn't the state use the data reported in the CMS 64 for actual rebate numbers?
I have to phone a friend on that as well.
Thank you.
Okay, thanks. So let me journey on, and we'll look a little bit at what was happening at the service category level. I'll note that Medicaid was much more nuanced than PEB was here, and hopefully PEB will be able to be more nuanced in the future in some of its analyses. So this breaks down inpatient, outpatient, and professional services. So inpatient, outpatient is inpatient, outpatient hospital services, and then professional. So you can see here again in 2020, big drop off in hospital service utilization, a little tick up in professional. But for the prior years, the inpatient trend was 15%. Outpatient was only 1.5%. It's a little unusual. We usually see the opposite, that the outpatient is trending higher than inpatient, and professional really high at 14%. And so these PEB trend numbers are high across the board. And some of this PEB's consultants Aon speculated might have been due to the introduction of the new benefit plan and higher spending associated with that being the EPO. Now, Medicaid, we've got a little bit more detail here, and you can see a little asterisk that basically says don't pay attention to dental. But you can see a breakout of what the trend looks like here, and the trend rates clearly they're a little strange for pharmacy. It's strange to see two negatives and then a whopping 47%. That equates to about 15% on average. I will say that in other states, I'm seeing double-digit annual increases in per capita pharmacy spend is not unusual, but this year-to-year fluctuation is a little unusual. For Medicaid, long-term care was a significant area of growth, and outpatient hospital. Okay, but you can see the biggest category for spend is professional services, but not growing quite as fast. Okay, and KYRA noted up here that this 4% growth in professional was due to growth in utilization. but for inpatient care and long-term care, it was change in price payment per service unit. Okay, here's a breakdown of utilization and payment per service unit, which is referred to here as a visit, but it's really per service unit because obviously an inpatient hospital stay isn't a visit per se. What you can see here is that it was price more than utilization that was accounting for growth between 2016 and 2019. So inpatient hospital, 1% versus 4%, 3 versus 5. And then down here, pharmacy, 2 versus 14. These patterns are similar again to what we see in other states. Generally speaking, in most states, in most years, it's increased payments per unit of service that's driving spending growth. And this is just Medicaid we're looking at here, but it's every bit the same in the commercial market, and usually actually more pronounced in the commercial market than in Medicaid. Chris?
So I know that I've said this before, but each time I look at numbers like this and look at, the trends over a period of time, the piece that feels like it's always missing from this page is a benchmark about how much we are spending. So I get the increases that are listed on here. I just am not clear if we should be spending what we're spending or if we should be spending more than we're spending, or maybe less, but you know what I'm saying? It's like we keep talking about growth, which I get is important, but what if we're underspending and some of these key areas are getting us to where we should be to make sure people have access?
Yeah, so the governor's executive order in setting a cost growth benchmark was to slow the rate of growth. Now, it's fair to raise the question, well, maybe we shouldn't slow the rate of growth, maybe we should spend more, but that's not what the executive order said. The executive order said we should slow the rate of growth in our spending. So that's why we are focused on measuring change over time in spending.
I appreciate that. Is there anything that will inform the PPC of those areas that are over national benchmark spending so that people can be more thoughtful about how they want to apply, how these elements should be applied? Like, it may be that we're over or under, and it may be that the group will be able to be sophisticated enough to say, I see that we're over in this area, but we are amongst the lowest in the US for how much we're spending in behavioral health, for example, because we don't have any. And so we certainly are encouraging and, recruiting and spending all this resource to put more, to give people more access. And then you see what I'm saying? It seems like,
well, I mean, this is one of the reasons that you guys exist, okay? Because you are advisory to them.
I gotcha.
Okay, that's why you exist, is so they can hear from voices other than the ones in the room.
Yeah.
So if that's a message that you want us to convey, then, pass on that message, and Melinda and Leslie and I will convey that to them.
Yeah. Yeah, it just seems like it might be helpful information because we also, all of us are worried about access in a lot of places. So
yeah, well, I will tell you, there are some other states that have cost growth benchmarks that have simultaneously set targets to increase spend for certain services. So for example, Oregon has a primary care spend target at the same time that they're attempting to lower overall rate of growth. So they're pushing up primary care while pushing down overall spending.
Yeah, makes sense.
Okay.
Okay. I appreciate that, Michael. And I just keep looking at this, and I am like, the piece that's missing for me is, are we good or are we not good? Should we be doing more or not, in certain areas? And I get that the focus is reducing the rate of increase.
Yeah, because I mean, the issue for consumers is, their wages grow at one rate and their healthcare spending grows 3 or 4 times as much. And what do employers do? Employers look at how much their health insurance premium went up, and then they decide, well, how much can I afford to give my employees in pay increases if that's how much more I'm going to pay for health insurance?
Right.
No.
But to your point about primary care, for example, spending more money there might save more money in other places. So
Right.
by looking at it at a sector level
Yeah.
and kind of checking us nationally, then
Mhm.
we might be able to focus and make it a win-win, grow the things that would be most beneficial,
Yep.
and more cost effective maybe. So.
Yeah, and because there are multiple states doing this, we can make comparisons. Whenever you make comparisons on absolute spending, you also have to take into account, the overall economy. I mean, so for example, people in Rhode Island always say, well, we don't get paid, the providers, we don't get paid as much as they do in Boston. Well, yes, but that's because the average household income and the economy in Rhode Island is nowhere near what it is in Boston. So you can't say in Rhode Island, I should be paid what they're paid in Boston, okay? Because the economy doesn't support that. So, so too, if we're going to compare Nevada to another state, we have to put it in the context of the economy. Make sense? Maya?
Yeah, I was just gonna, I appreciate the points that Chris raised. And I think I haven't fully thought this through, but in terms of thinking about if we are comparing ourselves to national kind of benchmarks or making a recommendation to the PPC on that it not solely be based on, spending benchmarks, because I think spending can be out of whack in a range of places. And so, if we're looking at access and utilization or access that we're not basing it solely on, do we spend less and does that mean that there's less access? I'm not sure if that's what was being conveyed, but I may not be articulating this as well.
So I think Chris's point is maybe we as a state want to invest more money in certain areas where we are underinvested.
Yeah. And but we're determining that not necessarily compared to what is being spent in another state. We're looking at other sort of indicators of where is a shortage of access.
Yeah, I mean, I think it's fair to make comparisons to other states, but yes, I think you would want to say, looking within the state, where do we think that we're having problems with access and where we want to make a greater investment while still trying to meet an overall goal of affordability.
Yeah.
Okay, so this type of analysis of looking at changes in utilization and changes in payment per service will be a continuing area of focus for the PPC. And so I want to highlight this for you. All right, so if we look at spend here and look at it regionally, we see some patterns that some of you might be familiar with. I had not been. I want to put aside this outside of Nevada because this is a very small percentage of the PEB population, and focus here on the South, North, and rural. So first, healthcare in the North is way more expensive than in the South. I mean, this differential is phenomenal. 434 and 255 is just wild. And we also see that that rural healthcare, and we saw this earlier, is expensive in the state compared to healthcare spending in the South. Okay, and trend over time is if we put aside the most recent year, somehow in the North, it grew 14% in a year where overall spending went down. I don't know how that happened, but spending growth was higher in the North and in rural parts of the state than in the South. So at an absolute level, it's lower in the South, and it's also growing slower in the South. And just the opposite in the North, where the rates of growth are high and absolute spending is high. Medicaid data also shows the North to be more expensive than rural parts of the state and the South, or most notably the South, although the differential isn't quite as dramatic as it is in the PEB population. And comparatively speaking, the rural parts of the state look more like the South than the North. So these are some clear geographic patterns. do you see this in some other states? Well, yes, actually, just west, you see it between Northern California and Southern California, where Northern California is much more expensive than Southern California. Okay, here's a breakdown of spending by gender. And what we see is that women covered by PEB have spending that's higher. That's because their utilization is higher. What we've also seen is that when men do utilize services, though, then they are more expensive. But in general, women utilize services more often, and spending associated with them is higher. The trend rates are about the same. By age group, this tells us that none of us should get older than 29. We should just stay at 29 forever. And that growth in spending is all indicative of higher levels of morbidity as people age. So none of this is surprising. In Medicaid, same thing. Most years, not so much in 2020, but most years the spending for women is a little bit higher than is for men. Given the high percentage of maternity services in the Medicaid population, that alone might explain this. But the rate of growth for both male and female are the same. This is something interesting. So PEB did not look at their data separating out infants from children and youth, but Medicaid did, and you can see super high spending. Now, this isn't surprising because most infants are hospitalized, so they're going to have a lot of spending in their first year of life. What is unusual is the rate of growth here. There's a 8% annual growth rate for infants, which is a little surprising. Okay, I'm getting near the end of the information I want to share with you. I want you to get a look at spending by health conditions, and I only have this information for PEB right now. These 5 conditions you see here accounted for 41% of total PEB spending between 2017 and 2020. Just these 5. And you can see cancer are the most significant of them. The fastest rate of growth, though, was infections, and that would include COVID for 2020, blood disorders, and mental health. The trend of increased utilization and spending associated with mental health is something that I've seen in other states too. Okay, so let me summarize my takeaways, and then I'll let you share what your takeaways might be. So first, prior to COVID-19's onset, spending was far above wage growth and state economic growth. So you can see Medicaid and PEB's rates of growth for these few years. I look back further for median wages and state economic growth, but this is the rub. This is why high levels of healthcare spending are problematic for consumers, employers, and taxpayers, because the healthcare spending is outstripping income and tax growth. Okay, and this is the reason that states created cost growth benchmarks and why the governor issued his executive order. So that's my takeaway number 1. Number 2, spending growth was highest for pharmacy for both Medicaid and PEB. 15 and 18% a year. I think that's higher than what I've seen in any state. It's really exceptionally high. Now, pharmacy growth is highest in other states too, but often at half the rate that you see here. Okay, for Medicaid, hospital outpatient was significant at 6%, and for PEB, professional was significant at 14%. So we don't always see complete alignment across markets. And if we were able to add Medicare here, we might see something different for Medicare. And also note for PEB, we really just have a couple of years of trend. And so, and they had introduced a new health plan. So the more years of experience we have, the clearer the patterns are. And then third, for areas with the highest spending growth, it looks like prices are the primary reason for the spending growth. Right, so let me pause now and ask for reflections that you all have. Sure.
A question on to why rebates were not included in the PEP analysis.
So usually when states are doing these, they don't factor in rebates because we're looking at change of year over year. And as KYRA said, it's hard to attach them to the individual year. So when we do the benchmark spending, we're going to net out rebates because the payers are going to report them. But when we're looking at year over year spending, generally states don't do that.
Does Massachusetts do that?
So there are two types of analyses. There's the benchmark analysis and there are these claim level. I don't know. I know what they do for their benchmark. I don't know what they do when they do special claims level analysis.
Okay. So earlier you mentioned that seeing double-digit pharmacy growth year over year was something that you see in multiple other states. What other states were those?
So the other states where we've seen high pharmacy spending are Washington, Massachusetts, Connecticut, and Rhode Island. They're not all double digit, but they're either high single digits or low double digits. These are the highest that I've seen.
So I'd love to see your data for those states because I have Massachusetts pulled up now, and they looked at pharmacy spending before rebates in the same time period, and they found a 5.4% growth and then a 5.8% growth in those different years. And then after accounting for rebates, they found a 3.7% growth for pharmacy and a 3.8% growth for pharmacy between 16 and 17 and 17 and 18.
Yeah.
All
fine.
of which were below the healthcare benchmark. So I think when we're talking about that, we need to be really responsible about how we're reporting out data from other states.
I agree.
It's not reflective of the experience that I'm seeing Massachusetts report out. It's not matching.
Well, yeah, but I mean, there is variation from state to state. And I mean, I just noted that these rates of pharmacy growth in Nevada are super high. I mean, every state is not the same. And, you know, we're also the shorter the time period, the more volatility you're going to see. And I would say, especially in pharmacy spending, I see a lot of volatility. I can see, you know, high spikes one year and then very modest rates of growth the next year.
Okay. And then are you all planning to go back and look at the impact of rebates and PEB?
So we're going to look at rebates thoroughly when we do the baseline cost growth benchmark analysis.
Okay. I'd just like to say for the record, and looking at the minutes from the executive committee of PEB, if you look at 2019 to 2020, after accounting for rebates, which the information is publicly available, the growth rate was -6%.
Wow. Okay. So when we collect data for the benchmark, we collect, and we're shortly about to do this for the baseline, we ask the payers to submit the rebate amounts. Okay. And so we report pharmacy spending growth net of rebates. This analysis just used claim data. It is unusual that KYRA did what she did. In the other states that have done claim level analysis, and I'm distinguishing that from the benchmark analysis, they don't try to match rebates to claims.
Yeah, and this is KYRA. I just would add that we started our analysis not taking into account rebates. And then when we went over our results with Medicaid leadership, they brought to our attention that, you know, sometimes there's an idea that pharmacy spend is a bigger piece of the pie for Nevada Medicaid than it is because of the rebates. And so we started this analysis, you know, not taking those off the top, and then thought that it was a little bit misrepresentative of the actual, distribution of costs in Nevada Medicaid. And that's why we attempted to take that off the top. And also just Azure, is it Azure?
Sure.
I have my team working on kind of an explanation as well around the CMS data that you referenced. So we did look into that, and we, for whatever reason, didn't think it was the best route. And I'll have a more thorough response to you. But I just wanted to let you know we started without that piece, and we put it on the top after the feedback that it was not maybe an accurate representation of pharmaceutical spend. And so just to Michael's point, this is going to be a fluid. We're going to kind of consider this a fluid analysis in Nevada Medicaid. We're going to just continue to refine this as we go. And so all of this is really helpful feedback for us.
Thank you. Appreciate that.
Anybody else have any reflections on what I've shared? Okay, so I've got two more topics I want to cover with you. Next one is how the PPC will identify and prioritize cost growth mitigation strategies. So it's likely over time that the state and other partnering stakeholders will not have resources to be able to address all potential strategies to mitigate cost growth. And so the PPC considered criteria for prioritizing those strategies that appear to offer the most promise. And as I noted earlier, when identifying what the PPC would be discussing at the next meeting, they're going to get into cost growth mitigation strategy soon. So I want to share with you the criteria that they have discussed. And it's about a handful of them. The first one is that spending data indicates that there's a significant opportunity for reduced spending or spending growth. And then significant opportunity is defined here. Number two, implementation of the strategy is likely to have a substantive impact on cost growth attainment. This means there'd be a measurable reduction in per capita cost growth at either a market level or at the state level. And there's either evidence that supports the strategy would work, or there's a really compelling logic model for the strategy, if there's no evidence. Three, strategy is actionable by either the state, payers, or provider organizations, depending upon who's the key actor. And then four, the relevant stakeholders have both the capacity and the capability to design and implement the strategy. So these four criteria were supported by the PPC. They left open the possibility of making modifications once they had actual strategies in hand to review. So my question for all of you is, do you agree with these criteria, and are there any proposed modifications that you would suggest or additions that you would make? And I'll go back to that slide so you can take a look. Any feedback? This is your opportunity. Okay. So last agenda topic is cost growth mitigation strategies. So you've seen something from the cost growth driver analyses. The PPC is going to be invited to consider cost growth mitigation strategies. So my question for you is, are there any that you would like to propose for them to consider? So I will remind you, you guys are the advisory body of the PPC. So if you want them to consider any notions aside from their own, this is your chance. Chris?
Thanks. So admittedly, I have not worked in a state where we were talking in these terms. So for me, it would be helpful if you could provide an example or two of what kinds of strategies states have implemented, just so I get a sense of the kind of thing that people have done. And I apologize that I didn't do a bunch of research and have a list ready for you, but
It's okay.
I'm
I
a
appreciate your
little at a
question.
loss.
Yeah, so there's no menu, okay? There's
Gotcha.
not a checklist.
Right.
And so it could be whatever you all think. I shared with you information on where healthcare spending in PEB and Medicaid appears to have been growing. And I did
Right.
that because it would make sense to focus on areas where spending's growing, right?
Gotcha.
So what have other states done? So, most of the cost growth benchmark states just got going in the last few years. So it's not as if we've got a long history, and they all operate a little bit differently, but I can give you a couple of examples. So there are 2 states that decided that the best way, or at least one way, for them to slow healthcare spending growth was to move away from a fee-for-service payment system. And so there are 2 states, Oregon and Rhode Island, where they brought together a bunch of stakeholders and they agreed and they signed a compact committing themselves to moving pretty aggressively away from fee-for-service payment for their healthcare systems. Okay, have they done it yet? No, but that's an example. Oregon passed legislation to more tightly regulate market consolidation because there's lots of evidence that consolidated markets have higher prices. And as I noted, data suggests that the problem of healthcare spending growth is not people using more and more services, it's higher payments per unit of service. And then finally, there have been a number of states that have introduced, fewer that have passed, but have introduced legislation that in some way addresses pharmacy price growth. Okay, that's that's not an exhaustive list. That's just a few examples.
No, I appreciate that. Thank you.
Yeah. And there are others. Karen. Karen, I can't hear you. It doesn't look like you're muted, but I can't hear you. No.
Karen, are you able to put your question in the chat perhaps? Okay, perfect.
Thanks for the suggestion, Melinda. Okay, so Karen said an analysis of high price drivers would be in order. And yes, that's a great suggestion. So all that you saw here, and really only for Medicaid, because PEB didn't even do this, was a very high order analysis of the role of price. But having a more nuanced understanding of what prices for what services, for which providers, that would certainly give us more insight. And that's a type of drill down analysis that I think we want to move into for the phase 2 analyses. And in fact, I've had conversations with KYRA about doing that, and hopefully PEB's going to do the same. But you're right, we need more nuanced data than what this shows. This type of analysis sort of points the compass in a general direction, but it doesn't tell us as much as we would want to know. Anybody else have any recommendations you'd like to convey to the PPC regarding cost growth mitigation strategies? Chris?
Thanks. So I appreciate this part of the conversation because I was struggling with the high level of analysis and then jumping to solutions without being able to understand, or be able to kind of have line of sight to potential waste. Because I do think that there is waste in the system, especially in the Medicaid area, as we force patients to receive their care in higher cost settings. I think we could do better. So I wonder if they're like similar to what Karen's talking about. I wonder if there's some deeper dives we could do to looking at long-staying patients, for example, people who are discharged to post-acute settings. Do they stay a lot longer than they need to stay in higher cost settings, that kind of thing? Because I think it would be a natural set of steps, and I think the industry, the delivery system, would be behind figuring out how to improve the efficiencies related to some of these high cost patients that get stuck in places.
Mm-hmm. Okay.
I have one more. The
Yeah, keep going.
the other area is use of the emergency room,
Mm-hmm.
especially for Medicaid. Because I do think, again, that we can do better. We're always trying to get people to the right level of care.
Mm-hmm. Anybody else? Okay, last call. All right, so let me talk to you about what's coming next. So I talked when Ashore was asking earlier about the benchmark analysis. We're planning a pre-benchmark analysis. The benchmark became effective this January. So there's going to be a baseline analysis that looks at the pre-benchmark period. And this says by June 30th, but actually it's going to happen in May. Commercial insurers in the state and Medicaid MCOs are going to be asked to submit data to the state for analysis for multiple years in advance of 2022. There's going to be a training webinar and office hours and an implementation manual for insurers. The data are to be submitted to the state by the end of August. And then during the fall, the analysis will be conducted, and in early winter, there will be public reporting of baseline spending that does net out pharmacy rebates. Okay, so that's on the docket. The analyses of these phase 1 cost driver analyses. So this was to be completed in April. It was to be shared with you in May, just happened today. The next steps are to move on to phase 2 and also to update the phase 1 analysis with 2021 data when they are complete. Won't be July 1st because the data won't be complete until June 30th, but sometime after that. And then, as I noted earlier, the PPC is going to make a decision, hopefully in May, on the 3 bills that they want to draft for the 2023 session, and then decide on them over the summer, maybe as late as September, actually, and then discuss pre-filing requirements for the 3 bill drafts. Okay. And they are next meeting on May 18th.
Right. Thank you so much, Michael. Does anybody have any other discussion on Michael's agenda items? All right. Hearing none, we'll move on to the next item on our agenda, which is public comment. Do I have any public comment? Please raise your hand if you would like to leave public comment. Okay, seeing none, we'll just move to item number 9 and we'll go ahead and adjourn the meeting. So thank you all so much for your time today and appreciate you serving on this subcommittee again. Thank you so much. Bye-bye.
Thank you.
Thanks, everyone. Thanks for those of you who participated. Bye.